It's my pleasure to reintroduce Dr. Robert Friedel, and I don't know if any of you have put two and two together, but this is the man who wrote Borderline Personality Disorder Demystified, which probably at least half the people in this audience have read, and the other half have heard about it. So, Dr. Friedel, thank you.
Thank you, Perry. And thank you all for staying. I'm glad it's not sunny out, or it's probably be 2 or 3 of us here. Or maybe it is sunny out and I just haven't recognized it. For those of you who, someone brought up the issue earlier today about patients and before they really start in treatment of any kind, before they're even evaluated, what is a way to more gently slide them into treatment, if you will, or at least being evaluated. I've got a website, and what I recommend to the people who call me is please have the person in your family who may be affected with borderline disorder or borderline disorder traits, have them take a look at that website, because it was designed to come on, if you will, a little bit more reader-friendly so that it's not so dissuading to people who may have the problem. Sometimes that works, sometimes it doesn't, but at least it may for some people involved.
What is the website?
The website? It's bpddemystified.com. Thank you for asking. As John said, it's just one more sign. And I don't need, well, we won't go to that. All right. That's not going to work. Do it the wrong way. There it is. This is a picture of my sister Denise. I like to show this picture when I ever give a talk on borderline disorder. She's on the website, and there's a little embedded video of my speaking of her when I was presenting several years ago. I do so for several reasons. One is that Denise was born a year and a half younger than I, and I learned a lot about borderline disorder without knowing there was such a thing when I was a youngster. Mother used to say in later years, and Ken may appreciate this, that she was one of the 15%, maybe John made the comment, she was one of the 15% who from the time she was born, my mother knew there was something different. My older brother and I had been born by then, and when she was born, Denise, Mom used to say as the years went on, I knew from the start there was something different. I could not comfort her as well. I could not soothe her as well. When she was upset, and she got more easily upset over little changes, little things, than the rest of you. Not that she did it all the time. It was not consistent. It was as in later years, she would have, if you will, crises, or as we used to say, when the demons were upon her. Between those times, she was absolutely wonderful. And not atypically, it did not manifest itself, her disorder, in its full fury until she was about 13 or 14. And like many people do, she, as I was indicating earlier, she showed this. It was a revelation. Looking back on it, it was difficult living through it because, as we've heard many times, and John emphasized this throughout his talks, the interaction between Denise and our mother and father was substantially different than it was amongst the four of us, the other four siblings, and our parents. There were two standards in the home. One standard was for her, and there was another standard for the rest of us. And at first we were a little bit upset by that, but after a while we came to understand Denise did not really learn well, did not respond well to the methods that Mom and Dad had tried and were pretty much proven, if you will, with us. They didn't work for Denise very well. And so they developed a new set of, if you will, approaches. I don't know what they were, but they seemed to work most of the time. She would not, the demons were not upon her that often, but when she got upset, she got upset. I mean, everybody on the block knew she was upset. Unfortunately, when she was in her early 40s, earlier than that, she had started drinking, and as frequently happens with people who chronically drink, especially with borderline disorder, it gets worse. She had diminished her gag reflex, and when she went out to dinner on her birthday with her family, was eating, got up from the table, left, excused herself, went to the ladies' room, and was found about 10 minutes later comatose. And unfortunately, by then she had been hypoxic for that period of time and had wiped out her cortex. And she was in a coma for the next 2 years before she passed away, blessedly. So she fell into that, if you will, the 9% of people who die prematurely for one reason or another as a result of the disorder. What it also helps me and reminds me of is that as little as we knew back then, and as little as we were to help Denise throughout her life, and she died some 30 years ago now, we know now so much more. There's so much more hope. There's so much more that we can do. And so it's obviously, it's not coincidental that this is an area that my academic career has to a significant degree revolved around. I'm going to review some of the issues that have been discussed. I'm going to review them because I believe they're central, and they're probably posed a little differently than you've heard. John, for example, used 3 behavioral dimensions, and as I understood what he was saying, he melded the last 2 behavioral dimensions to some degree into one. This is the traditional, if you will. These are the 4 dimensions of borderline disorder, which are now most acknowledged. And in addition to that, they're the ones that in random controlled, placebo-controlled trials of medications, these are the ones that have been used in the latter years as treatment endpoints. So it's important to understand them in that context. And we'll get into that more as we get into some of the biology of that, because it makes sense to break them up. And Ken has given us very nicely the background for that with his statistical approaches, because what we're looking at is not a disorder with just a few genes causing it, like Huntington's, that can be laid to all that 1 or 2 genes or even a few genes, but multiple problems. And in this case, probably in at least 4 different circuits in the central nervous system that coincide, maybe more, that coincide to some degree with these behavioral dimensions. 2 to 6% of the population, the old numbers were 3 to 1, the newer numbers, in only one study, which I must confess I'm a little skeptical of, it's still, I believe, it's still about 2%, it's still about 3 to 1. If you run the numbers on that, what you come up with is something rather striking. And that is, if it's really 2% of the population with a 3 to 1 gender ratio, 1 out of every 33 women and 1 out of every 100 men have borderline disorder. Think of it that way rather than 1 or 2% in whatever ratio. That never registered with me. It only registered with me when I made the conversion. 1 out of every 33 women, 1 out of 100 men. That means every single one of us, whether we know it or not, know a number of people with borderline disorder. Disproportionately high use of the medical resource, 6% of all medical visits, I don't mean psychiatric, I mean to primary care physicians, surgeons, and so on. 10% of psychiatric outpatients and 20% of inpatients, high mortality rate, 9%. Can you imagine another disorder in America with a mortality rate of 9% that didn't get as much attention or that gets less attention that borderline does? This is one of the issues that moved, I think, Congress when they passed that resolution back a few years ago. That and some other things that we'll look at today. Also, remarkably and gratefully, most of the research that's been done on this disorder has been done over the past decade or two, three. And that's why so many people who were of my sister's generation didn't get proper care. In spite of all that, as you've heard today, many patients with the disorder are either not diagnosed properly, or if they are diagnosed properly, are not getting good care for one reason or another. We just don't have quite as much information as we'd like to have. There was a question on the course of the disorder. As I've said, it starts oftentimes in adolescence, not necessarily, but it can, in many cases, start in adolescence and become clearly diagnosable in adolescence, and certainly by early adulthood, in most cases. Although I must confess I have seen in the past few years a gentleman in his 70s who was diagnosed for the first time. It's not that his onset was in the 70s. I diagnosed him for the first time in the 70s with the disorder and put him on appropriate medications, and he received some supportive therapy and has done very nicely since. A little bit upset that all the years he'd seen people, he was not diagnosed correctly. But it's still different than the age of onset. This is important. The symptoms vary significantly between patients. Remember, you've got 9 symptoms for this disorder. Possible criteria. So any 5 of them. Think about the permutations and combinations of those symptoms. There are many, many ways the disorder can present. And it can range from mild to severe. That is very important as well in terms of treatment. As you'll see, both with medications and as I was implying earlier in my question to Dr. Gunderson about and making deep interpretations or doing uncovering psychotherapy with someone who possibly might be in a severe mode of this disorder, have a severe form of disorder, that's probably not a great idea, as he said. It's important to remember that. More than 50% of those affected show significant reduction of symptoms, not full remission. I have never read a single paper that has indicated that they've had a full remission. Now, they may have had a remission by the criteria, but that doesn't mean that their symptoms have fallen below as a group. They may have now 3 criteria, 4 criteria, as opposed to 5. So they don't meet criteria anymore. So we could say, well, they're in remission. You're in remission I believe when your symptoms are not disturbing you at a more than mild level. That is, when your symptoms are under control for whatever reasons, as opposed to disturbing your life. 3 severe symptoms as opposed to 5 mild symptoms. If it's me, I know which way I'm going. That's not hard. So that's, I think, one of the concerns about the categorical diagnosis. I'm not in favor of the dimensional diagnosis in DSM-5 the way it's presented. As I read it, it's almost unusable clinically. There's no way that a clinician could sit and do this kind of evaluation. We've got to come up with something better. But I wouldn't throw the baby out with the bathwater here for a number of reasons. The prognosis, therefore, is enhanced by early detection and effective treatment. Helen answered this question, I think, very, very nicely. There is not wonderful data that supports this, but those of us who treat a lot of patients with borderline disorder are quite impressed that the earlier we can get to them, get them going on the right medications, on the right psychotherapy, help them along, their symptoms will decrease substantially, and over their life they may need much, much less treatment and sometimes no treatment at all. We'll get into that a bit later, too. Negative predictors, we've already heard. Impulsivity is one of them, which does, in some patients, decrease with age. Substance abuse is, in my experience, a very, very difficult co-occurring disorder. We'll talk more about that. Early sustained abuse, I think Ken spoke nicely to the effects of sustained and early abuse on people, increasing the risk as one of the risk factors. There's a good psychological reason for that. There's a good biological reason for that that dovetails beautifully. So it is, when one thinks of, well, is it nature or is it nurture? No. We had those arguments 50 years ago in psychiatry. I thought they were dead when we put schizophrenia and bipolar disorder and a number of other disorders and understood, no, it's not either or, it's a combination of both, and how much risk each is contributing and so on that causes the phenotypic expression of the disorder. Long-term ineffective treatment. In my experience, the more a patient has had long-term and ineffective treatment, the more difficult it is for them to respond to treatment. And I think that's not surprising for two reasons. One is, of course, they're discouraged about the whole notion of treatment. But it's also, I think, there's a biological basis to that. And that is, the more that circuitry is allowed to run rampant in their brain, the more it strengthens, the more difficult it is to reverse it. And so it's, again, important to get in early, do the right things, and go from there. And as Dr. Gunderson said, please interrupt me at any time. I'll be happy to stop and try to answer the questions. Yes? Ineffective treatment, as Dr. Gunderson showed you, that treatment as usual. That is, not knowing which medications to use, not knowing which the borderline specific psychotherapeutic interventions are, that are in what order, if you will, when to select one versus another. Not all psychotherapies, even borderline specific psychotherapies, are good for all patients. So if you try an analytic approach, as Dr. Gunderson was saying, on a patient who requires supportive therapy, you're looking for trouble. And vice versa, if there's a patient who's capable of moving ahead rather nicely because that's the nature of their particular illness, it would be a shame to shortchange them and not give them the full benefit of all of the treatments that could be available to them. It's easy for me and the residents with whom I work, and my patients too and their families, because when I see them, if I've made the diagnosis of borderline disorder, I hand out a copy of this. And what I go over quickly are the 4 dimensions of the disorder and describe within those dimensions those particular symptoms that the patient has reported to me and to the rest of the staff during the initial interviews, or the parents have seen as well. So we put together, if you will, a collage of symptoms, but they're always under these 4 categories, and I'll show you the individual criteria in just a few minutes. Having made the diagnosis of borderline disorder, it's also relevant to, at the same diagnostic interview, to go around the wheel. And I start with substance use disorders because it's my experience that, and this has been reported, that about 65% or so of patients with borderline disorder suffer comorbidly from substance abuse disorder. We will get into in a few minutes why there's such a high overrepresentation of other disorders with borderline disorder. There's a very rational explanation for that. The second is anxiety panic disorders, and then eating disorders, as we've heard of. If you'll just notice the prevalence here, they're oftentimes 10 times what they would be in the normal population. Now, whether these numbers are correct, and I'm going to have to go back and check Ken's recent data on this and other people's data to see what this is now maybe a year or 2 old, to see what those new numbers are. PTSD, attention deficit disorder. Attention deficit disorder, for example, is 5% in the non-borderline population. It's 25% in the borderline population, 5 times overrepresented. Now, why is that? As heritable a disease as ADHD is, it's one of the most heritable of all medical illnesses. Why is it 5% overrepresented in borderline disorder? Same with mood disorders, they're overrepresented. Now, the thing that I always emphasize in my first interview and wrapping it up with the patient and their family is if they have serious substance abuse, I point that out and say, nothing that I can do to treat the borderline disorder or any of the other co-occurring disorders is going to have any therapeutic effect unless you, the patient, stops the substance abuse. Do you think you're able to do that? If they say no, my response is, okay, I understand. This is not a good person, bad person test. This is medicine. You have to tell me what your symptoms are and your realistic appraisal of them, because then we'll discern a different therapeutic program for you. Some people say, no, I need antabuse. People say, no, I've tried antabuse, and I just go off it when I want to drink. Well, for them, the fallback position is a 30-day program, and if they've been in 30-day programs 3 times, I don't care. They got to go back into a 30-day program. And they've got to get out of that program and stay in an ongoing program while we start the treatment, because we can't start as long as that's going on. The reverse of that is mood disorders. If someone comes in with borderline disorder and a co-occurring mood disorder, I'm not talking about the depressive episodes that people with borderline disorder go through, and that's very important to discern those. A patient will come and say, I'm just depressed. I've been depressed for weeks and weeks and weeks. So I will, of course, try to validate that with family members. And they'll say, no, not really. Their boyfriend broke up with them 2 days ago, and they were fine before then. That is not a major depressive episode, either of the major depressive disorder type or the borderline bipolar type or an NOS type. It's just not a depression of that type. If it is, however, if they meet criteria, then I will do something that I don't do for any of the other disorders. I will co-treat at the initial interview or whenever I start medications, the treatment for borderline disorder and the mood disorder. My experience, and the reason is my experience has been if I just treat the borderline symptoms, it does not work nearly as well if I treat both together. There is a tremendous amount of conflicting data out there, I assure you, that one doesn't affect the other, one does affect the other, and I can tell you that clinically, we're back to Helen's responses, clinically it's my experience that I am, maybe in someone else's hands, maybe they're good at doing it, I'm just not, and so I treat both together. Again, I think the thing that's helpful to me about this is it enables me during the diagnostic interview and during my follow-up interviews to quickly focus in on the major issues, clinical issues, to not get lost in one symptom or one problem, breaking up with the boyfriend, losing a job, having to leave home, whatever, but rather making sure that I've got a good, clear clinical picture. I've done essentially my physical exam of psychiatry on this patient during this visit, and I record it. That's good medicine. That's the way I was taught to do medicine. That's the way I do medicine. Then I look for the potential triggering factors as to why that may be going on. It's an interesting phenomenon that when you plot out the different borderline dimensions, the only one that's surprising is this emotional reactivity one. And you would think that, for the most part, patients will have some periods when they're in a normal, if you will, range of emotional reactivity. And that's the point I was trying to make earlier in one of my questions. And that is that this disorder is, I believe, is not a trait disorder that is persistent and is the same most of the time. There are some times when, as Helen puts it, they look wonderful. People with borderline disorder just look terrific and they're just delightful to be around. Yes, ma'am. We're going to come back to those. Sorry, I'm away from the mic. Question was, what about the other disorders? I glossed over those very quickly. We'll come back to those and what we do for those. That a lot of the time, the importance of this slide is to indicate to you that a lot of the time people with borderline disorder are not in a borderline crisis. They're doing very well. Are they cured? I don't think so. But are they in remission? I think they are in remission. However, if they start having symptoms, it's important to record what symptoms. One of the things the thing that for me is interesting, and I think we've all observed it clinically, is this issue of below normal emotional reactivity. And how many times have we seen patients who have borderline disorder and something terrible has happened in their life? And they come in and they say, you know, I'm handling this a lot better than I thought I would. And, you know, everyone's so proud of me, I'm proud of myself. And I'm sitting there making a big note in dark ink, get your phone ready because you're going to get phone calls. And I even say to the patient, look, I'm glad you're handling it well now. If you find you're sliding a little bit, please give me a call. Or if they're seeing a therapist, please give your therapist a call right away. Don't let it go. Because they can slide into if you will, a suicidal, self-destructive state pretty quickly. Get drunk and then do something that's life-threatening. And I want them to know that, if you will, diminishing of their normal emotional response, to me is a signal, watch out. The 3 criteria from the 9 fall into at least what I think of the emotional dysregulation group. Not surprisingly, the intense episodic dysphoric irritability, the anxiety and the panic attacks, the anger. The anger is so important that the people who designed DSM-4, by consensus, chose to split it out as a criterion from the other emotional dysregulation symptoms. And then the chronic feelings of emptiness. And John makes a very good point. This is a tough one to place. It's not clear whether this is a relationship, cognitive problem or an emotional one. I think it's one that is emotional, and we'll get down when we move on to the neurobiology. I'll try to make my case for that. There are 2 in the impulsivity area. You can read as well as I can read. The third one is not in there, but it's very characteristic of people with borderline disorder. Always reminds me of my sister. When I was about 16, I had a set of golf clubs that I had saved every cent for. And we didn't have a lot of money, so I was saving every nickel. I had a nice set of old but matched irons. And in the middle of one winter, came in. I was trying to get them cleaned and ready for the summer, and asked Denise, asked all over the house, looked everywhere, and finally she walked by and I said, Denise, have you seen my 5-iron? I can't find it anywhere. And she looked at me and matter-of-factly said, sure. She says, it's out I broke it in half, it's out in the snow. I said, no, really, Denise, what'd you do with it? She said, really? I broke it in half and it's out in the snow. I said, what are you talking about? Why in the world would anyone break a golf club? She said, I got angry with you last week, don't you remember? I said, sure. And she said, so I did it then. So, and sure enough, when the snow melted, there it was, broken in half. That's the kind of anger that someone with a disorder will have, resulting in destructive acts, fighting with mother and father. It's rare for a child or adolescent to hit mom and dad. When they hit mom and dad, they've caught my attention. Because that's not common. The cognitive perceptual disturbances, we haven't heard too much about those today. I think they're amongst the least addressed in borderline disorder, and I think to some degree they help us to separate out borderline disorder from, let's say, bipolar disorder, where there's overlap in the emotional and in the impulsive areas. Because the identity disturbance that you see in borderline disorder, I don't see it in bipolar patients. The paranoid ideation that comes and goes, it can be lightning quick. One moment you'll be talking with them and everything will sound fine, and then the next minute you're planning with my husband and my boss to have me fired. And as a resident, one of my patients who I didn't even know about borderline disorder was telling me this. And all of a sudden I'm thinking to myself, and I'm doing inside-oriented psychotherapy on this patient. And I'm thinking, my goodness, what is going on here? So I quickly sat her up, had her look at me, and went through that again. And after a while, she settled down and returned to her usual self again. I thought, my God, what is that? So I went and saw my supervisor, and he said, welcome to the land of borderline personality disorder. You have just seen your first micropsychotic episode. You don't see that in too many other disorders. Now, there are only two, therefore, in the cognitive perceptual disturbances. The dissociative episodes are, of course, we've talked a bit about already. The split thinking John has talked about, and as he said, that's not splitting people. It's the inability to pull together, to integrate in your mind at the same time, opposing, conflicting ideas. One says yes, the other says no. One says black, the other says white. And you're thinking to yourself, how can these two things coexist? What am I missing? What needs to happen for both of these or neither of these to be so? Rather than to just slip automatically into one camp and forget the other camp is even present. That type of thinking is very, very peculiar to people with borderline disorder. At some level or another, if you ask them, do you think that way? Do you find that you're thinking black and white, all or nothing, whatever? Their spouses will jump up, and if they say no, the spouse will say, what are you talking about? That's exactly the way you treat me. There's an expectation of malevolence, a suspiciousness that's there oftentimes. They don't expect out of other people, as folks who don't have borderline disorder typically do. The people in general are good, and they're out there to try to make the world better and help us out when they get a chance, and when we get a chance, hopefully help them out. People with borderline disorder are somewhat withdrawn from that concept. They walk in the room and people are laughing. Their immediate thought is, they're laughing at me. Rather than, hey, this is a fun group. They're having a good time. Boy, I'm glad to be here. No, it's, I don't want to be here. They're obviously picked me out. They don't even know me, and they're already laughing at me. There's impaired social reasoning, which goes to a question that we heard earlier today. Under stress, when the emotions are running high, are people able to think themselves out of it? And as John, I agree with John totally on that. It's been rare in my experience that when people are on that emotional high, if you will, where they're so angry that trying to speak reasonably, we all get there ourselves, which is why people say count to 10. But usually by the time we've reached 10, we're back down to the level where we can then reason again. Forget that with people with borderline disorder, because it may be the next day before that emotion will get down to the point they can reason. There's an impairment of memory, too. They don't remember things. They will frequently say, I don't remember having that argument with you. I don't remember hurting you or doing this or that and whatever. And that sounds like they're just being deceptive, defensive, and not apologetic. My sense is over time they're probably not remembering as well, and we'll talk about that in a minute in terms of the biology of what's going on in their brains. We've also already talked about the micropsychotic episodes. Oh, I forgot to tell you, if you're following your slides, since I submitted those slides, I've reorganized them. So if you all of a sudden find that you're out of place, please slip back further down the list. The slides are there. They're all there. They've just been reordered to make this a little bit, at least for me, understandable. Lastly, the disturbed relationships. The two that are critical there are the first two. Those are criteria. The dependent, clinging, tumultuous relationships are not part of the criteria of borderline disorder, but we frequently see them in people with borderline disorder. We've gone over this, I think, extensively today. We've heard 35% to 70% number of times. The one item here that's wrong is the oligogenic. As Ken said today, the newer data suggests that most mental disorders and probably most disorders in medicine are not oligo, meaning few genes are not working well. Monogenetic is like Huntington's. You've got one gene, you've got the disorder. Oligo, few genes, you've got the disorder. Polygenetic means you've got a lot of genes, you have the disorder. It's which genes you inherit determine to a very significant degree how the disorder will present itself, and also to which environmental stresses you are going to be most vulnerable. Because if the circuit for you is working well, that requires that it work well under certain stresses, that's not going to be as devastating for you as if you were a person where that particular circuit that's controlling that behavior is impaired somewhere along the loop. Then that circuit is weakened. Then when you add the environmental stress to it, it's more likely, if you will, to break or to work in a way that's really not working well at all. So in a sense, the notion of the either or, I think, is resolved by an understanding that the brain is set up to handle emotional stimuli. Or forget emotional stimuli, all stimuli. And as long as the brain is supposed to bring it in, do something with it, determine how to deal with it, how important it is, and determine how to deal with it, it's got to be flexible. And we have to learn it's got to be, as we use the word, plastic. It has to change in its structural anatomy. It has to change in its chemistry. And over time, those changes, be they for the bad, with sustained stress and weakened circuits, or be they for the good, by enhancing the activity of the circuits first through medications and then through therapy, then that makes a big difference. Not all breakdowns in circuitry, by the way, in the brain are genetic. It's important to realize that some are developmental, either suffered intrauterine, excessive smoking, alcohol intake by the mother, and so on and so on, infection, whatever, and some postpartum, immediately postpartum, if there's a problem with the delivery. The APGAR score is particularly abnormal. Those can interfere, of course, with specific and certain circuits in the brain. Some of them may affect the circuits that are important in borderline disorder. The psychosocial stresses, we've already touched on the early separation or sustained abuses, a spectrum of ineffective and non-nurturing parenting, and do the psychological factors affect the brain? Absolutely. They have to affect the brain. If they don't affect the brain, we haven't learned anything. Our brain isn't working, or at least certain pathways are not working. So our brain must change as different experiences occur to us in life. And if we have a circuit or a genetic vulnerability early on in life, if you will, and something happens to us during that window of time that accentuates that vulnerability, the downstream biology that is controlled by those genetic processes, whatever the proteins are made, whatever the enzymes, whatever the substances that flow from them, they will be impaired. And again, the degree to which that insult keeps on being piled on in the absence of being effectively relieved and the pressure taken off, that circuitry is not going to be as readily amenable to treatment in the long run as it would be otherwise. Okay, let's just jump right into this medication thing. There are really three important reasons to use medications in people with borderline disorder. First is they reduce the inappropriate and unfortunate emotional responses and impulsivity. They enhance the thinking and reasoning, and they improve the quality of relationships. In other words, either alone or together, they hit all four dimensions of the syndrome, of the borderline syndrome. They enhance effective psychotherapy. The lady I was talking about earlier, one of my earliest patients, the one who had a micropsychotic episode, she was in therapy for 2 years. She made about that much progress. Now, I was a beginning resident, so I figured that's about par for the course. But eventually I tried and convinced her that maybe she should go on a little bit of medicine. So I got her on a very small dose of a neuroleptic. And within weeks, everything we had gone over seemed to start to stick. She would know it. She'd come in and say, I know I took the wrong option, Dr. Friedel. I know I should have done this thing over here, but I couldn't help it. I did it anyway. She started to come in and say, I had the feeling last week about doing this. I thought, oh my God. She'd say, but I didn't do it. I thought about what you'd say, that, you'd work through the alternatives with me and say, okay, which one? And then I'd have to say, well, it's this one, but I didn't do it. I decided, this time I'll do it. And that's the way therapy started going from then on. Do you think I changed in any way my style of therapy? That I became a greater therapist in a few weeks? I don't think so. I think to some degree the medication was enabling her, bringing the emotional reactivity down to a level where she herself could then control that. And the same with impulsivity, and the same with her ability to reason and so on. She was then essentially in the ball game. As much as I say to my patients, if you've got a blood sugar of 300, I don't care how hard you diet. You can't bring it down to normal. But if with insulin you can get that thing down to here, then lay off the 4 or 5 jelly donuts, and maybe you'll get it back down here. But laying off them up here just isn't going to get you back to normal. You've got a severe case, you need the medicine. You need to take it. I know you don't want to have diabetes, you need to take it. And finally, treating the borderline disorder in general enables you to treat much more effectively the co-occurring disorder. And sometimes it's more than one. Sometimes it could be 2 and 3. So for all of those reasons, it is important to move ahead. The other reason we talked about earlier, why do people get discouraged in psychotherapy easily? What's going to get them to come back for the second session? In my experience, what helps is if indeed in a few sessions you can figure out with them a medication that does relieve them, if not totally, substantially, of at least one symptom that's really for them very problematic, that will help them to gain a little bit more confidence in you. Because remember, they've seen 8 or 9 psychiatrists or psychologists or social workers before they ever saw you. And so you're not only not under a halo, you're under the blackest of black clouds. You've got a lot of work to do to get to ground zero as a treating clinician. And so the faster you can get in there and do something to help the patient, the better. Now, what are the classes of medications that are most useful? I was saying earlier, this whole field has turned itself on its ear in the last 3 or so years. Before, it used to be the SSRIs and, to some degree, the SNRIs, the norepinephrine receptor inhibitors. They were the treatment of choice of borderline disorder. No longer, and you'll see why in a second. Now it's the antipsychotics, number 1, and the mood stabilizers, number 2. Probably not in that order. They should be ranked as both first-line treatments, but for patients with different symptoms as they present. Okay, this is the critical number here, 2006. You are now looking at a list of every review that I can find in the literature, other than, of course, like a one-page review. I'm talking about a serious academic review, scholarly review of the literature in this field. There are 10 of them in 3.5 years. What does that tell you about this field? Well, it says a number of things to me. First of all, there's a lot of folks out there that just don't understand why there's such a great discrepancy in what we're saying, those of us who think we know what we're doing, about this disorder and its treatment with medications. And secondly is that there are new methods of analyses that have come into place. The meta-analyses have now come into place and are giving us additional, I think, a different approach to the methodological process of interpreting the data as opposed to the usual just scholarly reviews that have been reported in the past. So I think all of these data are now converging for us in a way that's beginning to make sense. Several people are now in the literature saying essentially what I've just said. Now here's the effectiveness as if you go through and you try to piece together those 10 studies and try to glean from them the data on what are the most effective medications for each of the 4 dimensions of borderline disorder. These are the medications that seem to have the most effectiveness to the, if you will, the lowest level of effectiveness, and different for different dimensions of the disorder, not surprisingly. The antipsychotics, the new ones, such as aripiprazole, and by the way, one study has shown quite tellingly, and the meta-analyses of this study bear it out, that aripiprazole or Abilify is the most effective of the atypical antipsychotics out there. I start with Abilify for 2 reasons. That, number one, it's the most effective, at least as far as the evidence is concerned. And number 2, it has the most gentle side effect profile. Does it have side effects? Yes. But it doesn't affect prolactin levels and a number of other things that the others do. It has a different mechanism of action, which is kind of interesting too. But then Risperdal and then olanzapine being the third. They work through 2 specific neurotransmitter mechanisms at the very least. This is probably the best hypothesis of how these medications work. They work as dopamine 2 antagonists first and foremost, and that decreases dopamine in many synapses. Not all synapses, but many synapses, because the brain is different. Some places have more and less D2 receptors. The forebrain, for example, has essentially no D2 receptors, almost all D1 receptors. The limbic system is loaded with it. So it's probable, and the thesis is it's working through the limbic system. The serotonin antagonism of these drugs is also there. Serotonin antagonism produces decrease, first of all, in dopamine in the synaptic clefts, but also decreases the amount of glutamate. Glutamate is the major excitatory neurotransmitter in the brain. We'll get to that on I think the next slide, or quickly. Thiothiazide and haloperidol, this is the first one we reported on in the same issue back in 1986. Paul Zoloff reported on haloperidol. Both D2 antagonists only decreased dopamine levels. I still use thiothiazide as my number 2 drug if Abilify doesn't work. Why? Because of the tremendous weight gain and triglyceride problem and other side effects that are caused by Zyprexa and Risperdal. If that doesn't work, then I go back to Risperdal, etc. I use that medication if there's considerable mild, that to me is moderate to severe, not mild, moderate to severe cognitive perceptual disturbance. Because it's the only drug that's ever been shown to work, or group of drugs. Only the antipsychotics, not surprisingly, work on this dimension. The others don't. However, if the patient presents mainly with affective disorder, aggressive impulsivity, and relationships problems, then I will start them on a mood stabilizer, typically lamotrigine. Lamotrigine, why? Lamotrigine, because lamotrigine has 2 benefits. One is it decreases, in some patients, cravings for substances of abuse and for food. And this disorder, as we said before, is just rampant with people who are obsessed with their weight and with weight in general. And in my experience, and a lot of people's experience, this is reported in the literature well, topiramate is the only anti-epileptic drug that will do that, the only mood stabilizer that will do that. And so I figure we're getting at least a 2-for-1, if not a 3-for-1 out of this particular mood stabilizer. I'll then go to Lamictal as the backup, lamotrigine. And if that fails, that has very little weight gain with it. It just doesn't decrease cravings. Then go on to divalproate. Divalproate works. The problem is weight gain. It works through different mechanisms than the 3 different mechanisms these drugs do than the antipsychotics. First of all, the voltage-stimulated sodium channels are decreased. Okay, what does that mean? That means just the conduction through the most of the cells in the brain is calmed down. It's working through, mainly on glutamate cells. Vic. Topiramate, because of the yeah. That they what? That there's a difference in response? Yeah. This is one of the times, fortunately, I don't have to use my clinical experience. This is the time when those 10 studies are converging very nicely in favor of topiramate, and the meta-analysis studies are more supportive of topiramate than they are of the other 2. And at least in my hands, I seem to have more success or good success with it. But the importance of this, in addition, is that the mood stabilizers have different mechanisms of action in the brain. They decrease glutamate activity, glutamatergic neuronal activity, the stimulatory activity, which we think is overreactive in the limbic system and hyporeactive in the frontal cortical system. We'll get back to that because that sounds contradictory. But we're trying to cool down, if you will, the limbic structures. It blocks sodium channels. That cuts down conductivity. GABA is increased. GABA is the main inhibitory substance, neurotransmitter in the brain. So that inhibits glutamate receptors and glutamate activity. And finally, glutamate function overall in another way is decreased. End result, decreased glutamate activity. These are 2 chemically distinct type of drugs. What does that mean anyway? Under those circumstances, if a patient has this kind of a problem and only has, let's say, partial response, and we've got them on good-sized, goodly medicine. I haven't pushed it all the way to the top. But I would then add the second medication to it. Because oftentimes coming at that overactivity from 2 separate chemical directions is better than coming at it one. Much as treating AIDS with the AIDS cocktail. You're coming at the problem 3 different chemical directions, you have a better shot. And you can keep the drug lowers. I ask you now, is that polypharmacy? Many physicians who don't know the mechanisms of action, pathways they're working through, and say, hey, you're well on your way to polypharmacy there, Bob. You're just getting started. My response is, I don't think so. I don't think it's polypharmacy at all. I think this is correct pharmacy, pharmacological application of known biological principles, much as it is with AIDS. Tell the person who has dying of AIDS that 3 drugs is polypharmacy and 2 is just right. I don't think you're going to get a very happy response to that question or statement. The SSRIs used to be number 1. Here's why the SSRIs are not so terribly good. Plus-minus effect in emotional dysregulation, mainly on anger, as that's understandable from what we know about it. And plus-minus on aggressive impulsivity, again understandable from what we know about it, but nowhere near the level here. And we also already mentioned the omega-3 fatty acids. 1 study, hard to make a springtime of that. Question? Yes, ma'am. We're talking about, I move my patients up, depending on their age, 25 milligrams a week, till they reach a level of 200. And the same with Lamictal. Lamictal even slower, because remember you can't move up lamictal too fast. You have to be careful. I'm sorry? Yes. I start with about half of a 5 milligram tablet. It's less expensive than buying 2 milligrams because 5 milligrams is typically the minimal therapeutic dose. And so then I'll keep them on that for 4 or 5 days and bump them up to 5 milligrams and go from there. And then the average therapeutic range will be somewhere between 5 and 15. Okay? Here's the problem we've got with medications, folks. This is it. This is why the 10 studies right here. We've got people in the field, for example, National Institute for Health and Clinical Excellence in UK. They control medications in the UK. And Joel Paris in Canada. No or minimal value of core symptoms of borderline disorder. That's their official position. I don't think that's consistent with the data. Then there's the middle of the road position, which is that medications are not primary. They're not first line. They're adjunctive. Therapy is first line. Once you see just 1 or 2 slides on the biology of this disorder, you may hopefully agree with my conclusion that at moderate to severe levels of the disorder, initially now, medications are first-line treatment used with adjunctive supportive psychotherapy. So I've flipped this one on its head. However, after the medications have been optimized, flip it on its head again. Now the medications do become adjunctive to the primary treatment, which is psychotherapy over the long run. It doesn't take that long to get the meds right. You can get the meds right a lot faster if you follow some of these guidelines. This is a different approach, clearly, than the ones we've seen. What are the causes of the problem? Some of them you've already heard, variations, methodological presentations of studies, heterogeneity of the populations. But the last one is the one I'm going to focus on for the rest of this presentation very quickly. And that's this disorder is not being conceptualized properly from a neurobiological perspective. Without it, it's like arguing how many angels can dance in the head of a pin. You might as well be in the game of philosophy, and that's not the field I entered. I always love this comment by Joe Ledoux. Joe Ledoux is a neuroscientist, very well-known neuroscientist from Cornell. The proper level of analysis of psychological function is the level at which that function is represented in the brain. Understand how it's working, understand how the brain works, and how that function is related to the brain, and you're off to a good start. Very quickly. These are in your book, so I'm not going to go into these in great detail. But in 2 slides, this is how the brain works. Okay? That wasn't hard. What did I spend all this time in neuroanatomy for, neuroscience for? Really. The major takeaway issues here are just a couple. Functions in the brain are controlled by neurocircuits and then complexes of neurocircuits, which we call systems, multiple integrated systems. Not a neuron, not a single pathway, not a place in the cortex. The connectivity of these things is now where most neuroscientists see the field. In fact, that's what biological psychiatry meeting in New Orleans is going to be all about. From neurons to neurocircuitry. Again, glutamate stimulatory, GABA inhibitory. However, there are other neurotransmitters in the brain. They're neuromodulatory. Billions and billions of the stimulatory glutamate and GABA. How many dopamine? Everybody's heard about dopamine, Parkinson's disease, and so on. You know how many dopamine neurons there are estimated in the brain? 100,000, compared to billions of this other. 100,000. You don't have to lose a lot before you got Huntington's. But they're very, very powerful neuromodulators. What do modulators do? It's a bit like a TV channel. Once you get the right channel on, maybe it's too bright, maybe there's too little color, too less color, the volume's not right. The neuromodulators turn the gain up or down on all different functions. They inhibit, they stimulate, but they modulate the gain. They give us moment-to-moment operating movement. The major circuit is doing what it does. How fast it moves, how much activity in that circuit, dependence on the neurotransmitters. The neuromodulators. We're going to slip by this because time is running a little bit late. These are the key structures known to be associated with the temperament factors of neuroaffectivity, negative affectivity, positive, and constraint. There are only a half dozen or so structures. But remember, I said circuitry, not structures. But these structures are critical. Just to show you, the amygdala we've heard a bit about. The amygdala's function is to take in information and decide, is this important or not? Is this something I should be concerned about? So information gets to the brain, gets spread to the amygdala makes a response and moves on from there. And it tells the rest of the brain, hey, not to worry about this, remember this, whatever. So it adds emotional valence to the brain. Look at the difference in response to neutral faces, happy faces, sad faces, and fearful faces in controls in borderline patients. Here's the amygdala down here. That organ is markedly overreactive. Why? Another story for another day, but it's markedly overreactive. Where's the amygdala? Here's the amygdala here in the brain. Right here. It's an almond shape from which it gets its name. This is the limbic system here. This is the hippocampus right here. Hippocampus is usually the first stopping place and the accumulation place for memories. Gathers from the rest of the brain, experiences, forms new memories, beginning of new memories. Look how close it is to the hippocampus. It wasn't. My guess is it was not placed so close to the to the amygdala for no good reason. We'll see in a minute why. Here's some other important areas: the medial orbital prefrontal system here, orbital right above the eye, the anterior cingulate body here, very important. And then, I don't see the nucleus accumbens here, but right about in here in the brain is the nucleus accumbens, very important in the reward circuitry, if you will, the happy circuitry. Okay, here's it on the brain. Dorsolateral prefrontal, the limbic circuits, anterior cingulate, dorsolateral prefrontal cortex here. Thinking. When you think dorsolateral prefrontal cortex, that's where we do conscious thinking. That's where we do reasoning. That's where, if the emotions allow us to, that's where we can make good decisions from. Activity in the circuits of that area. We're getting close to the end. Okay, here's the fun one. Walk through this with me quickly and it won't be so terrible for you. Here's sensory coming information either from outside or from within the brain. Makes no difference. A memory or a thought of some sort, or a physical experience comes into the brain. The thalamus splits the message in two, sends quickly information down to the amygdala. Amygdala says, is this important or not important? Is this something that's life-threatening? Is this something that's going to make me feel good? Should I approach? Should I avoid? What should I do? It's in contact, remember, with the hippocampal formation. So it's depending on memories, recent and remote memories, and this is the vehicle to get information to the amygdala. Once it's got its information, it sends information out to the nucleus accumbens. The nucleus accumbens is the major source of dopamine fibers, positive dopamine fibers, up to the thalamus again. Thalamus is kind of the spreading point. It's kind of the major switchboard of the brain. And the thalamus sends, in the green means go. Hey, this is terrific. Go do this. It stimulates the devil out of the brain. It says, do everything you can to keep this coming. Whatever it is, this is good. Remember this for the future. And do it now. However, if it's not so good, and by the way, this is the dopamine reward pathway that you hear so much about. This is the pathway. If it's stimulated in rats electrically, they'll die from starvation, even though they have access to food. They're much more interested in pushing the lever for the stimulation to this area of the brain. This is, again, the feel-good area. Now you see the negative affectivity, the positive affectivity. Negative affectivity through this one. This is a no-go. This is fearful. The amygdala doesn't wait for the information to come from the cortex and start controlling regulated conscious behaviors. The amygdala starts immediately into automatic mode. It's the fast circuit. It's meant to be fast. We haven't got a lot of time to sit and think, is that thing coming at me a car, or is that just a shadow? We get out of the way. Then we stop and think, well, maybe, maybe not. So this circuit is very, very fast, and it's regulated through the brainstem. This circuitry gets up to the brain, and that's where areas like the prefrontal cortex come into play. If the prefrontal cortex reads something as, hey, this is a no-go, and it says, maybe not. This is, you picked up the wrong tone, or you picked up the wrong cue. This is really not a go. The prefrontal cortex sends regulations back through the nucleus accumbens and through other mechanisms not shown here to the rest of the brain saying, cool down. Don't do this. Do not respond emotionally to this event. Think this through some more. You need time. So a combination of different areas of the brain have responsibility for controlling impulsive behavior, thinking things through, dorsolateral prefrontal cortex. You can see where all of these functions, these circuits, are involved in the symptoms of borderline disorder. The thinking now is that this circuit, the amygdala circuit, that's the fearful, whatever, negative affectivity circuit and so on, overreactive. You saw the amygdala overreactive? It's overreactive. It's given a no-go to the brain in a lot of ways, giving no-goes to the emotional responses. It's causing us to behave inappropriately. There's too little coming back from the top saying, calm down. I've reasoned this through. Calm down. You're overreacting. This is what's happened. Here's your emotional response. Pull it back down again. It can't do that because it's so far overreactive in people with borderline disorder. Just like insulin, patient with diabetes without insulin can't handle the sugar. The forebrain cannot handle the amount of impulses that are getting through to it from the amygdala and lower levels of the brain. That's where the medications come in. Now, why different medications? Why so many genetic flaws have to be present? Every one of these little arrows is, if you will, is part of a circuit. It has receptors at one end. It has all bunches of chemicals in its neuron. It has all bunches of chemical down it. It has chemicals it releases. Bunches and bunches of chemicals. They're all controlled individually by genes. How many places along this circuit can things go wrong? In other words, a lot of places can go wrong. So the accumulation, as Ken pointed out beautifully this morning, in this entire circuitry, and this is just the circuitry involved in borderline disorder. Imagine other disorders more complex like schizophrenia. There are so many circuits that you can see why only a small percentage of risk factor from any gene can accumulate, because there's so many opportunities for genetic expression within the central nervous system. As Ken said earlier today, if we think some organs in the body are complex, think about the brain, the complexity of the brain, enormous. One final note, just to put in perspective what Ken said and what I've said. The brain weighs about 1.5% of the total body weight. Anybody want to guess what percent of the cardiac output it gets? Wild guess. Anybody? 20. Good guess. Good guess. It's 25%. 1/4 of every stroke of the heart sends blood to the brain, which is 1% of the total body. That means the brain's doing some really serious work. I mean, even in resting state, forget about thinking and problem solving and stress. It's why we need more sleep, as Joe was saying earlier. It's why we need more sleep when we're under stress and so on. We got a lot of restorative work to do. Thank you very much.